Hello, Dr. Shatreet. You read the echo on my patient today. This is a gentleman that has a history of difficult to control atrial fibrillation. He's had ablations, he's had cardioversions, he's status post AV node ablation with a biventricular pacemaker. He's been intolerant to heart failure medications previously, bilateral carpal tunnel, Achilles tendon rupture, peripheral neuropathy, and he even had 2 CVAs despite therapeutic INRs. So his ejection fraction has been stable at 46% for years, but we lost him for a few years from COVID, and I'm looking at his echocardiogram today, and gosh, I'm noticing his walls are thick. And then I'm kind of like, this guy has red flags for ATTR amyloidosis, especially wild type. He's 72, and I'm concerned the thickened walls could be trying to tell us he might have amyloid. To your eye, as an echo expert, do you think the echo has parameters that are consistent with ATTR wild-type amyloid?
Thank you, Janelle, for bringing this case to my attention. Did you say he had a history of bilateral carpal tunnel syndrome, Achilles tendon rupture, and now he's intolerant to his heart failure medications? He definitely has a number of red flags that make us think of cardiac amyloidosis. The misfolded proteins, they deposit in so many places. Why don't we take a look together and see what we can make of his echocardiogram? This gent's walls are thick. What did you say he was known for? Has he ever been diagnosed with hypertension?
You know, he hasn't had hypertension to my knowledge. In fact, we've really had a hard time getting his cardiomyopathy medications to goal when he had the tachycardia-mediated cardiomyopathy. So he's never had hypertension. In fact, it's always been too low.
Well, a septal wall thickness of 19 millimeters is certainly abnormal. And his intolerance to blood pressure medications is suggestive of transthyretin amyloid as well. Would you happen to have his ECG?
Yes, we did get an EKG today, but the voltages weren't low, but I know that they're not always low in all amyloid patients, and when they are low, it can actually be a late finding in an amyloid patient. So we don't have that other clue like we do with the echo.
Let's see what else we could find in this echocardiogram. Sometimes assessing the right ventricle is a great indicator of an infiltrated process, since the proteins really don't discriminate between the left and right ventricles. In this case, we clearly see that the RV free wall is thickened. I think you're onto something, Janelle. What else can we see? Well, there's no significant aortic stenosis. Sometimes, in cases of amyloid, we may very well see aortic stenosis, particularly of the low gradient type. Not the case here. The tissue Dopplers are often really abnormal and very low. We look for the 5-5-5 rule, representing the S prime, the E prime, and the A prime. We sort of see that in this case. What we're looking for is the way the annulus moves away and towards the ultrasound probe. It also reflects diastolic function, which is often significantly impaired in cases of cardiac amyloidosis. The 5 represents the velocity of the tissue, and we're looking for 7 to 10, just typically a normal range. So this is clearly abnormal. I don't see a pericardial effusion, but the interatrial septum is clearly thick. Also, I don't know if you can appreciate this, but the muscle is sparkling. Should we have a look at the strain?
Gosh, thank you. That was a really comprehensive look at the echocardiogram and exactly what I was looking for. Yeah, I would like to know what the strain is. That would be very helpful.
So, 2 things jump out here. Firstly, the strain is abnormal. So this muscle isn't healthy. Secondly, there's a cherry on top pattern, or that apical sparing pattern we look for.
So we've got thickened walls, we've got significant diastolic dysfunction, muscle sparkling, abnormal strain, and apical sparing pattern all suggest the possibility of amyloid. It looks to me like we need to do further testing to confirm.
Certainly, but we have to have a couple of things in mind. You really need to make sure the strain was acquired properly. If the regions are off, an apical sparing might show up. Also, some conditions associated with old age, like severe mitral annular calcifications, can cause the basal segments to be abnormal on strain and give an apical sparing type pattern. Conversely, you can have patients with cardiac amyloid who have previous coronary disease, specifically an infarction of the left anterior descending artery, causing dyskinesia of the apex, and instead of causing an apical sparing pattern, causing a blueberry on top pattern. This pattern will be misleading, but should not dissuade the reader to suggest the remaining features suggest amyloid. That being said, this echo really suggests an infiltrated process like cardiac amyloidosis. Is the troponin level elevated?
That is such a good question, but since we've never suspected amyloid on this gentleman before, I didn't draw it in his pre-ordered labs, so unfortunately, I don't have that data point.
Not a problem, Janelle. We often expect an abnormally elevated number.
Exactly. Is there any chance that there's another cardiac disease here?
It's always possible. There are some common disorders like high blood pressure and chronic kidney disease, or there's some rare genetic disorders that can give us some similar findings, so-called amyloid mimickers, if you will, on an echocardiogram. Take, for example, Anderson-Fabry disease, which is a lysosomal storage disease. Not only is it a multi-system disorder that affects the nerves and the kidneys, but you also end up with a thick heart. Fabry's patients might have mild aortic dilation, some valvular regurgitation, and instead of the apical sparing pattern, they actually have regional dysfunction in the basolateral walls on strain imaging. That being said, if we could take into consideration the clinical history and this gentleman's echo, cardiac amyloidosis is high on the differential. We just can't be 100% certain. The echocardiogram remains an important screening tool at best. I would definitely encourage downstream testing in this patient. And a side note, even if it's suggestive of cardiac amyloid, we can't reliably differentiate between light chain or transthyretin amyloid, which are the two major types of amyloid deposition in the heart.
Thank you, Dr. Shatreat. Your input has been incredibly helpful. Given the pyrophosphate scan, otherwise known as a PYP scan, has excellent sensitivity for ATTR cardiac amyloid, I will move forward with that. The ACC-AHA Heart Failure Society of America 2022 Heart Failure Guidelines describe the role of cardiac scintigraphy with PYP scan. The use of a PYP scan allows for non-invasive diagnosis of ATTR cardiomyopathy. Cardiac uptake is performed by a visual scoring method or a heart to contralateral lung ratio. A grade of 2 out of 3 or H/CL score of greater than 1.5 suggests a positive result. To avoid a false positive, SPECT images are required to confirm. And as you said, we need to be mindful the PYP scan can be positive in AL amyloidosis too, so it doesn't exclude AL amyloid. Therefore, even though this patient doesn't have red flags for AL amyloid, such as macroglossia, periorbital purpura, weight loss, foamy urine, or proteinuria, we will get free light chains, serum and urine protein electrophoresis with immunofixation to rule out AL amyloid.
Sounds like a plan.